Hello, my dear students, welcome. We're going to discuss local anesthetic agents on this module. Local anesthesia. These drugs are applied or injected locally. They produce reversible loss of all the sensations in a restricted area where you have applied them or where it's supplying, without producing a loss of consciousness or without any structural damage. The small unmyelinated fibers are more sensitive, which transmit temperature, pain, and the autonomic sensations. The motor fibers may get affected, leading to paralysis. Let's have a look at this table. This is trying to compare general anesthesia versus local anesthesia. In the left column is GA, that's general anesthesia, and the right column has LA, that's local anesthesia. General anesthetics are administered in a way that they enter the systemic circulation, whereas the local anesthetics are applied or injected locally. With general anesthetics, the consciousness is lost, and with local anesthetics, there is no affection of consciousness. General anesthetics agents act on the central nervous system. That's their side of action, is CNS, whereas the local anesthetics are acting on the peripheral nerves. General anesthesia affects whole of the body, whereas the local anesthetics, they affect restricted area. When you give general anesthesia to the patient, you need to take extreme care about the vital functions. When you give local anesthesia, the vital functions are usually well maintained and you don't have a great amount of worry as you have in general anesthesia. General anesthetics are CNS depressants. Local anesthetics are not expected to depress the central nervous system when you are working peripherally. General anesthetics also produce depression of the cardiovascular system and the respiratory system, whereas with local anesthesia you don't expect CVS and RS depression. General anesthesia is preferred for major surgery, and under local anesthetics we carry out minor surgeries. General anesthetics usually are given by the route of inhalation, drugs like halothane, enfluorine, isoflurane, etc. Or there are intravenous anesthetic agents like thiopentone or propofol. The local anesthetic agents are used locally or applied locally. If it's applied to the mucous membrane, it's called surface anesthesia. And when you start injecting it, it may be infiltration anesthesia, it may be nerve block or conduction block, or it may be spinal or epidural anesthesia. What's the mechanism of action? How do they act? We need to remember one keyword. They are sodium channel blockers, and they inhibit the entry of sodium. And when the entry of sodium is inhibited, the rate of rise of the action potential and the amplitude of the action potential gets affected, and the depolarization is blocked. So we say it's depolarization block, and the nerve impulse is not generated, so that's generation block. There is slow conduction or propagation of the nerve impulse. That means the conduction gets affected, so that's called conduction block. So we have three words: depolarization block, generation block, and conduction block. All these three together constitute what is called membrane stabilization or membrane stabilizing effect. The local anesthetic block the voltage sensitive sodium channels. They raise the threshold of the channel opening. They prolong the inactive state of the channel, and they increase the refractory period of the nerve impulse. Let's have a look at the classification. This particular slide is showing you the injectable local anesthetics. The injectable local anesthetics could be divided into three sections: low potency and short duration, that contains procaine and chloroprocaine; intermediate potency and intermediate duration, you have lidocaine, prilocaine, and mepivacaine; and in the high potency long duration, you have tetracaine, etidocaine, debucaine, ropivacaine, and bupivacaine. Bupivacaine has been written in capital letters here with blue color. Is to remind you that bupivacaine is the longest acting local anesthetic agent. I also want to tell you tetracaine has got another name, and that's called amidocaine. And debucaine is also identified by two different names, and that's cincocaine and neoprocaine. We were speaking about the low potency, short duration, intermediate potency, intermediate duration, high potency, long duration. After the injectable anesthetics, we have surface anesthetics, which are applied locally. And you have soluble and insoluble surface anesthetics. Amongst the soluble local anesthetics, important one is lidocaine. You also have tetracaine or amidocaine. You also have cyclomethicane. And there's a last drug mentioned here is cocaine, which we don't use as local anesthetic, but classification wise, it's a surface anesthetic. The insoluble surface anesthetics include benzocaine and butyl amino benzoate. There's one interesting thing about local anesthetics. Sometimes local anesthesia produces a very severe hypersensitivity reaction, and it's mandatory that you do the hypersensitivity testing before giving the local anesthesia. The patient has come to you for a minor surgery, and it's not good that the patient gets a very severe hypersensitivity reaction. What's the strategy? What's the theory behind these hypersensitivity reactions? Local anesthetics can also be classified or also can be discussed as esters versus amides depending on their structure. Whether you are an ester or whether you are an amide. So on this slide I am dividing them into ester linked and amide linked. And look at the ester linked local anesthetics. This group contains procaine, chloroprocaine, tetracaine or amidocaine, benzocaine and cocaine. And there is more incidence of hypersensitivity reactions with ester-linked local anesthetics. The reason is most of these drugs get converted to para-aminobenzoic acid, and that's the substance responsible for increased incidence of hypersensitivity reactions. The ester-linked local anesthetics are having one I in their spelling. I would like you to visualize now them as far as the spelling is concerned. Look at the spelling. Procaine, P-R-O-C-A-I-N-E, chloroprocaine, P-R-O-C-A-I-N-E, tetracaine contains only one I, benzocaine has one I, and cocaine has only one I. And let's go down now to see the amide-linked local anesthetic. Look at the spellings. Lidocaine, prilocaine, mepivacaine and bupivacaine, dibucaine, etidocaine, and ropivacaine. I hope you are looking at the spelling. Look at the spelling of the amide-linked local anesthetics. Lidocaine, L-I-D-O-C-A-I-N-E. Because there's C-A-I-N-E in each of these drugs, you are going to have this one I. In addition to this, you have one more I. That's one of the beautiful ways of remembering which ones are amide-linked local anesthetics. May I repeat? Ester-linked drugs in their spellings have only one I, and the amide-linked drugs have in their spelling two I's. That's the way you can remember that these are amide-linked local anesthetics. The ester-linked are metabolized by plasma cholinesterases, and the amide-linked are metabolized by hepatic amidases. And we said already the chances of hypersensitivity reaction are more with the ester-linked group, and there's a cross reactivity within the group. For example, if you use an ester-linked local anesthetic for a patient and he had hypersensitivity reaction, next time if this patient comes for a procedure, it's better to avoid the ester-linked local anesthetic, because if he is allergic or hypersensitive to one drug from this group, he is likely to be allergic to all the other agents from the same group, and that's called cross reactivity within the group. Lidocaine in general produces less incidence of hypersensitivity reactions. So that's about esters, amides, and the hypersensitivity reactions. In general, we prefer amides. Amides have got intense action, they are quite long acting, and the hypersensitivity reactions are rare. What are the uses and techniques of local anesthesia? The first one is surface anesthesia, in which you apply the drug to the mucous membrane or to the abraded skin. Lidocaine, tetracaine, dibucaine can be used for this. Next is the infiltration anesthesia, in which you go below the skin, that's the subcutaneous injection, which is useful for minor operations, minor procedures like suturing a wound. Next, you go on to block larger and larger areas, and it's all called conduction block. So you block a small nerve and the area supplied by that particular nerve, or you go to a larger area like a larger field is blocked, or you go to block nerve trunks or plexuses. Lidocaine, procaine, prilocaine, etidocaine, mepivacaine and bupivacaine, many of them, they can be used for conduction block. The next type of local anesthesia is spinal anesthesia. Doesn't appear to be local anesthesia, but it's supposed to be local anesthesia. The drug is not supposed to reach in great amounts to the systemic circulation. Spinal anesthetic is injected in the subarachnoid space between L3 and L4. That's the usual site. Spinal anesthesia is safer as compared to the general anesthesia because there's lesser risk of the cardiovascular effects. There's good amount of analgesia, there's good amount of muscle relaxation without a serious loss of consciousness. The next type of local anesthesia is epidural anesthesia, in which you inject the drug in the dural space, in the thoracic, lumbar or caudal spaces. And the last one is intravenous regional anesthesia, which is practiced sometimes, and lidocaine, bupivacaine and etidocaine could be used for this. It's good to have some important information or facts about lidocaine, which is probably the most widely used local anesthetic. Number one, it's an amide, and there's less chances of hypersensitivity reactions. There's rapid onset of action, and there's fairly long duration of action. Suppose the drug is given depending on the site and depending on the concentration given, you can get a duration of action of 1 to 2 hours. And there's minimal local irritation. It's useful by all methods of local anesthesia. It does not show, obviously, any cross reactivity with procaine. And just to remind you, lidocaine, when used by intravenous route of administration, works as an antiarrhythmic agent because it's a sodium channel blocker, is going to be a class 1 antiarrhythmic, to which we are definitely going to refer when we do the module on antiarrhythmic drugs. The next agent which I am going to discuss is procaine, and it is an ester type of local anesthetic. There's some special reason for discussing procaine. Procaine does not penetrate sufficiently through the mucous membranes. Its penetration through the mucous membranes is very poor. And if a drug is not able to penetrate the mucous membrane, for example, let's talk about the anesthesia in the eye. If the drug is not acting, not penetrating, we could not use this drug as a surface anesthetic for the anesthesia in the eye. You got to remember this. Procaine is not used as a surface anesthetic. You can choose it as a local anesthetic for other methods of anesthesia. In addition to this, procaine has got a slow onset of action, and there are two more drugs which could be derived from procaine. Number one, there's a salt of procaine with benzyl penicillin. It's a long-acting penicillin. And the second important fact to remember, that procaine converts into procainamide. That's an amide of procaine, and it's again a class 1 antiarrhythmic agent. Procaine is a derivative of para-aminobenzoic acid, and I hope you remember just a few minutes ago we said this para-aminobenzoic acid is responsible for the hypersensitivity reactions. So ester type local anesthetics produce more incidence of hypersensitivity reactions, and you need to remember procaine because that's the representative drug from this group. The next slide writes to remember, because this slide contains many important facts. Let's have a look at it. I've written on the top bupivacaine. This time it's in green letters. The first time you saw it, it was in blue. What is the reason for making it blue? Just give a thought. Why did I make it blue and why did I make it capital? Do you remember it? Okay? We said I made it blue because the longest acting local anesthesia. I hope you're getting it. Bupivacaine produces adequate analgesia without significant motor blockade and produces longest duration of action. Bupivacaine has got beautiful tissue binding, and that leads to the long duration of action. For example, if you give it by the route of infiltration anesthesia, it could act for 2 to 3 hours, and sometimes even up to 24 hours if the drug is given in sufficient amounts. This slide is telling you to remember one more thing. That one more thing is about cocaine. All of you know cocaine is a toxic agent and it's a drug of abuse. It's abused. And cocaine, when instilled into the eye, produces mydriatic effect, produces tachycardia, and produces vasoconstriction. The reason of this is cocaine inhibits the reuptake of norepinephrine. And this is why norepinephrine accumulates, and the effects of cocaine that you are getting are the effects of norepinephrine. Vasoconstriction by stimulation of alpha receptors, stimulation of the heart leading to tachycardia, and dilation of pupil to produce mydriasis. All these are the effects of sympathetic nervous system, and you get these effects because cocaine inhibits the reuptake of norepinephrine. Cocaine is toxic to be used as local anesthetic. In addition to this, you have a risk that it will be abused. And the last important point is, if you put it in the eye, it's going to produce vasoconstriction, and this is going to lead to lack of blood supply, which could be dangerous to your cornea. And this is why cocaine should not be used as a surface anesthetic. The next drug mentioned on the slide is LIDOCAINE. I'm mentioning it because sometimes on your multiple choice questions, you're likely to get a question on methemoglobinemia. LIDOCAINE is one of the local anesthetic agents which is known to produce methemoglobinemia, just like your nitrates, which are used for angina, are known to produce methemoglobinemia. The last drug mentioned on this slide is tetracaine, and this is too toxic, and it's used or reserved only for surface anesthesia. Now let's go and see what are the other actions of local anesthetics. We need to know this because we are going to give these drugs by local routes of administration, and you don't expect the drug to go in the system of circulation. But by chance, if there's an accident, you inject it in a larger amount, someone else uses it by error, and if the drug enters the systemic circulation, what's going to happen? We need to know the other actions of local anesthesia. Number one, if it crosses the blood-brain barrier and goes to the central nervous system, they produce central nervous system stimulation, and it's followed by depression. One of the examples is cocaine, which produces euphoria and dysphoria. The second action is on cardiovascular system, and I hope you remember I said their basic mechanism of action is sodium channel blockade. So they are going to do the same thing in the heart, and they are going to be myocardial suppressants. They are going to be sodium channel blockers. Remember LIDOCAINE, remember procainamide. Most important thing to remember, the longest acting local anesthetic, bupivacaine, is the most cardiotoxic agent. LIDOCAINE, in comparison, has got less effect on the contractility of the heart. As far as the myocardial suppression is concerned, LIDOCAINE is supposed to be comparatively safer. The third thing in the cardiovascular system we're going to get due to local anesthetics is the hypertension, is the fall in the blood pressure. This happens due to the sympathetic blockade and direct arteriolar dilation. Bupivacaine is most likely to cause hypertension, and LIDOCAINE is least likely to cause hypertension. The last point to be mentioned on this slide in the other actions is, once again, to revise, cocaine produces vasoconstriction, tachycardia, and increases the blood pressure. In general, when the local anesthetics are given, what adverse effects do we expect? There are minor adverse effects like lightheadedness, a sense of dizziness, headache, auditory and visual disturbances, confusion, disorientation, but not possible with the usual dose of local anesthetic. If you go on increasing the dose, there's likely to be disorientation, twitching, involuntary movements, and seizures. Sometimes the drug can produce bradycardia, hypertension, and arrhythmia due to the quinine-like effect and the cardiovascular collapse. Local anesthetics can sometimes produce delayed wound healing and local tissue damage. Bupivacaine is known to produce local irritation, and some local anesthetics, as we discussed, produce hypersensitivity reactions. A very large amount of dose of local anesthetic in systemic circulation can produce respiratory failure. So, it's good to know what are the precautions we need to follow while using these local anesthetic agents. It's always good before injecting a local anesthetic, when you put your syringe and needle, aspirate slightly before you inject to confirm that you are at the right place. Number 2, the injection should be given slowly. Number 3, confirm the dose. Do not exceed the safe dose, especially when it is an issue of injecting local anesthesia to the children. It's good to know if this patient is receiving any other agents. You know, a beta blocker, propranolol, is known to decrease the metabolism by decreasing the hepatic blood flow. In this situation, the local anesthetic, which is normally not expected to produce an adverse effect, can produce an adverse effect because the hepatic metabolism breakdown is decreased. The local anesthetics which are soluble, they are likely to get absorbed to the systemic circulation. And when you inject local anesthesia along with epinephrine, that's adrenaline, you need to ensure the patient doesn't suffer from any cardiovascular conditions. For example, ischemic heart disease, hypertension, heart failure, and another condition which has got sympathetic overactivity is thyrotoxicosis. Let's have some interesting discussion about lidocaine epinephrine combination. That's one of the most widely used combination throughout the world for all the minor procedures. And it will not be an exaggeration if I say this is probably the most common therapeutic use in which epinephrine is used. Lidocaine with epinephrine. What happens? Epinephrine acts on alpha receptors, which are in the smaller blood vessels, stimulates the receptors, produces vasoconstriction, and as you know, when there's vasoconstriction, there's decrease in the blood flow to this area. When the rate of blood flow to this area is decreased, the lidocaine which you have injected along with epinephrine keeps on entering over a long period of time. It enters slowly, and naturally you get a long duration of action of lidocaine. So the purpose of giving epinephrine is to prolong the duration of action of local anesthesia, and that's called time synergism. You get additional advantages is because the blood flow is less, there's less chances of the drug, the local anesthetic, to enter the systemic circulation, so there are less chances of systemic toxicity of the local anesthetic. And since there is vasoconstriction, the bleeding is going to be minimized. What are the contraindications? Don't give this combination when you are injecting to an area supplied by end arteries. For example, the male sex organ, the fingertips, and the toe tips. So also, don't give this combination to the patients who are suffering from various cardiovascular conditions. At the end of the discussion of the local anesthetic agents, it's worthwhile to spend a few slides or little discussion on spinal anesthesia. Spinal anesthesia is supposed to be a type of local anesthesia, and the local anesthetic drug is injected usually between L3 and 4 in the subarachnoid space. The nerve root in the chorda equina gets affected, and you get the anesthesia in the region of the lower abdomen, the perineum, pelvis, and the lower limbs. And the operations lasting for about 2 to 2.5 hours could be conducted under spinal anesthesia. Some example is the cesarean section, the obstetric procedures, management of fractures in the lower limb operations, procedures in the pelvis, perineum, and the operations on genitalia like hernial operations and urological procedures. It's suitable for older patients, and it could be used in patients with chronic obstructive pulmonary diseases, patients suffering from diabetes mellitus, and hepatic and renal diseases. For spinal anesthesia, bupivacaine 0.5% or lidocaine 2% or 5% may be used. You may combine it with epinephrine, and syncocaine, tetracaine, mepivacaine, ropivacaine are the additional agents which you can use. What are the adverse effects or complications of spinal anesthesia? One important thing is the hypovolemia. If the blood volume is less, it's going to be dangerous if you perform the operation or procedure under spinal anesthesia. It could lead to hypotension, and the common adverse effects like headache, NV, that's nausea and vomiting, dizziness, and photophobia are known. Rare adverse effects include bleeding in susceptible patients, respiratory paralysis, and the neurological complications including septic meningitis and the cora equina syndrome. Are there any definitive contraindications to spinal anesthesia? Yes, it's not good to give spinal anesthesia to patients suffering from hypovolemia, hypotension, dehydration, diarrhea, vomiting, or bleeding, clotting disorders, or the patients on anticoagulant therapy, patients who are mentally handicapped, suffering from psychiatric disorders, or the children, and if there is sepsis on the back. It's not good to give this anesthesia to vertebral column deformity patients, pre-existing spinal cord lesions, and neurological diseases. If there are inadequate facilities for resuscitation, spinal anesthesia is contraindicated, and the last contraindication, of course, is the patient refusal. So I think we tried to review the local anesthetic agents. We divided them into esters and amides to know that the esters are likely to produce the hypersensitivity reaction with more incidence. We also discussed in details about lidocaine, procaine, and some highlight points about bupivacaine and cocaine. We gave adequate amount of weightage to the epinephrine local anesthetic combination, and at the end, we discussed spinal anesthesia. I request you to make a good use of this beautiful small module and succeed on your exams. All the best. Thank you.